We're having trouble with the Tokyo connection. Did you? It's a time zone thing. Can you guys hear me in the back? Good. How is everybody? We are here at a breakout section called Making the Case for Independent Patient Advocacy. And we thought that it was appropriate to do it at a conference that is made up of a lot of people that are healthcare advocates, but they are not necessarily working directly for the patients. And it is somewhat of a nomenclature issue, to say the least, because if you're in the hospital and you ask to see the patient advocate, you're getting somebody from legal, risk management, reimbursement, administration, pretty much. But that doesn't stop these well-intentioned people who take the job with a description and a title called patient advocate, probably thinking that they're going to be working for and, helping patients. We're here to talk about the people who have realized that there are failings within the healthcare system that only somebody with the experience, having worked in that system, and also the benefit of working outside of that system, can tackle. So there's been a lot of conversation at this event. Oh, I'm not doing slides.
Oh, you have slides.
I don't know. There's been a lot of discussion, business to business discussion, sales discussion, reimbursement discussion among all of the patient and healthcare advocates among us. Those don't represent the independent patient advocates. So a few people just walked in. The definition of an advocate. Anybody really answer that one right off the top of your head? I mean, there's a couple of them, but the main one is somebody that fights or pleads the cause of another. And in the context of healthcare, that usually means somebody who's incapable of communicating on their own behalf. Now, we have health professionals in attendance, correct? People who work in quote unquote health care, whether you're in pharma, whether you're in pharmacy, whether you're in sales. You guys think you know all the lingo. You're confident, right? I mean, we're dealing with people in this room that actually go into doctors' offices and talk to them and sell them on latest therapies, treatments, and plans. You would think that those people would be equipped based on their comfort level. If they became a patient, you'd think they'd be able to speak up for themselves. But that doesn't happen. That's not real world. Real world is that when you become a patient, you can't speak up for yourself. You lose all ability, all semblance of reality, self-esteem. The minute you get wheeled in on a cart, the minute you're laying down with a horrific looking robe with your butt hanging out, and everybody's coming up to you and they're looking down on you and you're looking up at them, that's not a position of power. And it wasn't the position of power that I found myself in back in 2004 when I thought I knew everything. Not because I worked in healthcare, but because I had the pleasure of being a lawyer and litigating medical related cases. Meaning, the way I'm talking to you guys right now, I talk to doctors like this. No big words, treat them like human beings. And I thought I would be able to handle that. when I called an ambulance because I had a really, really, really bad headache. This was in 2004. I called the ambulance, went to the hospital. It was a Saturday. It was a holiday. It was spring, and it certainly looked like that. I had a second shift skeleton crew. Everything that could have gone wrong did go wrong. I went in with this headache that got worse, symptoms of pre-sepsis. 10 hours later, full-blown septic shock, but not a single antibiotic, no care, no real treatment. And I wish that I had somebody in that room with me, because if I would have, I wouldn't have woken up 30 days later from a coma with no limbs. It was all because signals got crossed, people weren't communicating, people were not familiar with their surroundings because they were temporary moonlighters. They didn't even know the system because the EMR record system was relatively new. But I didn't have anybody with me. I went back. I became a lawyer all over again, thinking I was going to save the world by fighting for people who had been injured by medical error. That's great if that's your intention, to wait for the mistakes to happen, wait for people to get all messed up and then get them some money. And that's what a lot of med mal lawyers do, but it wasn't working, but people are calling. They don't know who else to call. I found out about independent patient advocacy after the fact. Turns out there were people that were leaving healthcare late 90s, early 2000s or so, probably way before that. But this is when people started going into business by themselves, saying, I am not going to work for the corporation or the institutional healthcare where I'm constrained and restrained. I'm going to work for people. And that's what independent patient advocates do. We take the knowledge and skills that we learned working within the system, as narrow as they may be. And most of the times, they're narrow by definition. And we use those skills to help people who need our help. The industry's come a long way. We've got a long way to go. In the early days, individuals were scattered all over the country. Then organizations formed, but they worked on their own, independent of the other organizations. It wasn't always easy. Find a patient advocate, independent patient advocate, or learn about them. But things are starting to change, and the organizations are starting to come together. And it is my pleasure to introduce to you the managing director of an organization called the Coalition of Healthcare Advocacy Organizations, Rachel Westlake. She's going to tell you about where independent advocacy has been, where we are now, and where it's going. So with that,
hi, everybody. Thanks, Brad. Thanks for telling your story so often for the benefit of us, because we're all patients. We're people first, but we're all patients. And I really appreciate you sharing your story so that everybody can get better at what they do. So I'm going to talk a little bit about the Coalition of Healthcare Advocacy Organizations, which is a coalition, not yet a formal organization, but a group of people working together to advance the profession of independent healthcare advocacy and bring leadership. So I'll tell you a little bit about how I got here. I am an independent patient advocate, and I'm an independent patient advocate actually because I had excellent care. I had a really bad diagnosis a couple times over, but I had excellent care. And I had the privilege of being taught by my family, the privilege of the community that I lived in, to feel okay about asking the right questions. So I learned as I went when I was sick with non-Hodgkin's lymphoma as a 15-year-old, and then again as a 35-year-old, that asking questions and managing my care was not only my responsibility, but my right. And I wanted to help other people do that. I have a background in social work, working in clinics, working for care managers and fiduciaries in various settings. And around early pandemic time, I opened my independent practice called Circadian Health Advocacy, working with young adult cancer survivors, mostly post-treatment, helping them manage their care, learn to ask the right questions, and really integrate from the difficult stuff that they've been through. They needed to integrate their psychosocial support, meet the financial toxicity component of what they went through, and start to feel into how to manage their care for the rest of their lives, because it was long and it was different and there's a lot of recovery. So that's who I specialized in working with. And then in 2022, started working with the coalition, bringing folks together to have inter-organizational meetings. So we are CHCAO. We call ourselves CHCAO in the way that you remember that. So it's CHCAO, which just looks awkward. But if you've ever seen Ferris Bueller's Day Off, have you seen Ferris Bueller's Day Off? Okay. Oh yeah? Did you say oh yeah? Do you know the song Oh Yeah by Yellow? It goes like this. I can't believe that I'm going to be recorded making these sounds again in my adult life, but okay, so it goes blah blah. So yeah, happened again. All right, so the work that we're doing that's back. The work that we're doing falls on the back of a lot that has come before. From 1960s to 1996, there was a lot of things that happened in healthcare, including the AHA introducing the Patient Bill of Rights, the formation of geriatric care managers, which is now known as the Aging Life Care Association, Pulse Center for Patient Safety, opened in 1996. Patient navigators were introduced into the Harlem Hospital in 1990. I'm all over the place, but so is that. So that's just a little bit that happened before 1999, when many of you have heard about that. Is the clicker? Oh. The 1999 Institute of Medicine report to Err is Human, building a safer healthcare system, which attributed about 98,000 approximate deaths to medical error. So that spurred a lot of patient safety work in the nation. These are some other stats that I'm going to kind of breeze through some of these slides because we don't have a ton of time. They are dense and written by a lot of really great, smart people. So there's some that we'll skim through, but they'll be available to you, and there's stuff to learn here. But, tons of statistics around dangerous mistakes, preventable harm in hospitals, dangerous shortcuts taken by care providers, medical error deaths, as we know. But all of this really comes back to the fact that these mistakes are made by good people in challenging systems that need to be fixed. So there was an industry response to these findings, and the Leapfrog group, the patient I'm sorry. Brad, the patient met with a diagnostic.
STM, Society for
Diagnostic.
Society to Improve Diagnosis.
Yes.
Yes, that one. Society to Improve Diagnosis in Medicine. All sort of came together to push this national response on patient safety. And then there was the consumer response. From 2009 to 2012, there was a big leap that Brad was talking about. A lot of organizations were formed to support advocates who work directly for patients and respond to this health crisis in the United States. In 2009, the founding of the National Association of Healthcare Advocacy Consultants, now called the National Association of Healthcare Advocacy, NAP, was founded, and at the same time was the formation of the Alliance of Professional Health Advocates, which is a friend of the coalition, and they provide a lot of the foundation for how advocates can start their private practice. An important marker here of the Affordable Care Act in 2010 and the Patient's Bill of Rights. There was also in 2012 the formation of WASHA, which became Health Advocate X in 2020, and the formation of the Patient Advocate Certification Board. All these folks, besides AFA, are in the coalition, but all of them are friends of independent patient and healthcare advocates. So we took another big leap in 2018 to 2022. The board BCPA exams were administered and certified candidates. The formation of Greater National Advocates in 2018, which is run by Brad, and the first official job task analysis study was done by the Patient Advocacy Certification Board in 2021. And this is a typo, pardon me, the Joint Task Force revised and updated the Code of Ethics for the healthcare advocacy profession. And in 2022, the formation of CHCAO.
There was less than 1,000 BCPAs. It's like it's gone.
There is, yeah, there's now more than 1,000 CPAs. I know.
We'll have to pick it up.
So I'll talk a little bit about CHCAO and some of the collaborative projects that we're working on. In general, our mission is to provide collaborative leadership that advances the profession of patient and healthcare advocacy. Member organizations are Health Advocate X, Greater National Advocates, the National Association of Healthcare Advocacy, and the Patient Advocate Certification Board. So in 2021, recognizing the need, the call from independent advocates, and a lot of conversations from the past, these groups got together to start to talk about how we could advance leadership and move the profession forward. And we expect that working together, because everyone has a very different viewpoint on independent health advocacy, a different lens, comes at it from a different angle, does different work for advocates, that together we can collectively provide leadership to the profession. The benefits of working together include enhanced visibility. We hope them to include enhanced visibility of the professional practice, being here as a coalition, sharing with you about who we are, talking to others, like many of the independent advocates here. We want to share with other allied health professionals, people who can refer, and let them know that we're here. We want to be able to expand the professional development offerings and help create, encourage, and enhance the development of academic programs for the profession, and get some recognition by the regulatory bodies. Here's hoping that this recognition by regulatory bodies and the connecting with allied health professionals and referrers will help us get in front of more patients and have more patients have access to independent advocates. So a couple collective projects. The job task analysis was one project that was performed by PACB, and I'll talk more about that, but included the collaboration of all members. And the Code of Ethics for Patient and Healthcare Advocates was revised. And general strategic restructuring, thinking about how these groups can better work together to support independent patient advocates, patient healthcare advocates. So I, of course, have like 3 sets of notes, which is really helpful. The revised Code of Ethics in 2022 was a collaborative effort by CHCAO member organizations, and it clarified the roles and responsibilities within the profession. A Code of Ethics is a responsibility for professional entities to create, and in the past couple of years, we know that there's been a lot of pressure on organizations to create living, good, accurate documents that help guide the ethics of what people do in their profession. And we expect that this document will be continually reviewed. So we ask for input from our advocates and things like that to make sure that that continues to grow. And as technology starts to come into play, there's many more opportunities for accidental or intentional unethical behavior. And while ethics shouldn't need to be taught, mistakes are made. People do unethical things in a profession. And so we believe that it is the responsibility of these professional organizations to really guide the ethical code. And we have an ethical code that has been created that is actually applicable for anybody in the domain. So whether or not you work as an independent advocate or if you work in an allied profession, you can sign on to the Code of Ethics, and that is available to be signed on to via our website, the CHCAO website, which I'll show you a little bit later. Another collective project was the job task analysis study. Some of you have heard a little bit about the research study performed by PACB on behalf of the professional practice. And the job task analysis study is another, first of all, it's required by any certifying board. And it's also inherently important for a profession to assess what tasks are actually being performed by people in the profession. So that's what that did. It helps us create a research-based job description rather than something anecdotal. And it's how we document the skills, knowledge, and tasks in this professional practice. It's how things get codified, and it's how the certification exam gets honed and developed. So one of the things that the JTA does is it informs the certification exam. These are a couple other ways that the application of JTA data could be applied, how JTA data could be applied. I'm not going to get into all of that right now, but you get the overall gist. It could help create job descriptions. It could be a part of talent development. And as I said, the certification exam is honed by it. And it helps us establish a distinct profession. A distinct profession has defining roles, responsibilities, and commitments that require a certain level of education, skill, or training. It establishes competency, knowledge, and education that must be demonstrated. And attached to a profession is a specific code of ethics, which we also have. So the JTA, who are the independent advocates? What did the JTA find? They are all these wonderful people. If you want more specific information about the JTA Phase 1 report, it is linked in the slides that you will have available to you. But it's found on the PAC Board website, the Patient Advocacy Certification Board website under Advocacy News. And it says JTA Phase 1 report, I believe. So the healthcare backgrounds of independent, or pardon me, not just independent patient advocates for this report.
Second, yeah.
Sure.
Just might work in facility, elder care professionals who work in a facility.
That I think that is not a good header.
I'm just checking.
Yes, thank you for catching that. So certain
department in a hospital.
Yeah, these are the backgrounds of where folks might have come from to become independent advocates.
Well, and it says retired nurses, doctors. Like a lot of us are retired.
Actually, I was given a very last minute note. Thank you for pointing that out. It is in my paper to take that retired out of there. So you didn't see it. It doesn't exist.
Yeah, we do live in Del Webb. I'm trying to get there.
Yes, don't see that word. Unsee it. All right. So the results of the healthcare background for the JTA, you can see that these last three columns are the biggest, and they include people who say they are practicing as health advocates, healthcare advocates, or patient advocates in some form or another, and they are saying, I don't have formal clinical or healthcare related education. They're saying I'm a registered nurse, or they're saying I am the magnificent other. And the other magnificent people this is how these folks self-identified. Yeah. So these are the main domains of how people identified if they selected other for their healthcare background. Primary practice settings. Some identified as independent, and in this case, independent and private are different because they might be independent, more solo entrepreneurs, and then private might be people who are working in a practice. Top areas of practice. These are in order of most selected to least. So most selected, decision support. And the patient advocacy lingo, for most of us, I think we all kind of think that means the same thing, but I'll say that, for example, that might be a patient advocate, independent healthcare advocate, helping a patient decide between different kinds of surgeries, providing them with good, credible, well-resourced information, and helping them figure out how each surgery might impact their life, and helping them figure out how to make that decision for their personal lived experience. So some distinctions between independent healthcare advocates and institutional advocates and navigators. Mostly has to do with who pays you, where you work, the setting in which you work. That's what I mean by where you work, and who you're responsible to. So Brad talked a little bit about the responsibility to the patient on the part of independent healthcare advocates. I want to talk a little bit too about how I know so much that institutional patient advocates, navigators in hospitals, even people who work in billing and insurance, they care very much and consider the patient to be their primary importance. So I would never ever suggest anything other than that. And I've had amazing experience with people helping me due to privilege in all of those aspects of my care. I would also say that sometimes they are pushed and pulled to have to navigate around who pays them. So finding an advocate. How do you find an advocate? There are several directories, as some of us know very well, and there are great ones and there are smaller ones, but you can find most of them through navigating to the CHCAO website. So it's CHCAO.org. Thank goodness it's just that. And you'll find links to Greater National Advocates that has an extensive directory to find independent healthcare advocates, healthcare and patient advocates, NAC, and the National Association of Healthcare Advocates and Health Advocate X are also on there. They have directories. Not on that list is the Advo Connection, which also has a great directory. Primarily, everyone on this website are nonprofits. That's why they're not there, or not primarily. Everyone on this website, everyone in this coalition currently are nonprofits. And PACBoard is also linked there, so you can learn more about the certification and what PACBoard does and find more information about the job task force.
Can you clarify? Does CHCAO have a directory or just links to the other directories?
Links to the other directories, yeah. We're not creating redundancies, we're just creating a hub for folks to find different information.
Right. Okay. Right.
So there are a lot of existing challenges and trends in healthcare right now. And they range from aging baby boomers, artificial intelligence, climate change, clinician burnout, COVID-19 and other pandemics and epidemics, health disparities, healthcare for all, improving operations and care in care settings, mental health, patient data from wearables, solo agers, staffing shortages. We all know about how severely we're hit by that, tech for equity, and telehealth. So we believe at CHCAO and as independent patient advocates that independent patient advocates are multifaceted, multi-skilled individuals who can, especially because they specialize, can help patients navigate all of those upcoming issues. And we believe a patient or healthcare advocate for every patient is possible. We're going to do what we can to help that. So that's the deal. Are there any questions about what we're working on?
Was that vision to have every one of those be certified with the BCPA? Is that what your goal is? To have them all certified?
Independent Patient Advocate is the goal to have them all be certified.
I don't think I think that we think that certification and licensure and credentials are really important for independent patient advocates.
I've said that to Terry when she was studying from that a couple of years ago.
Mm-hmm.
And so I respect everything that she does.
Mm-hmm.
I couldn't do that. I couldn't pass the test.
Mm-hmm.
But I would want somebody helping me out to be, passing that test.
Yeah.
I'm trying to say.
Yeah, it's not an easy test.
But if someone doesn't want to go through the exam, is it still a good thing to subscribe to the code of ethics?
Oh yes.
That would be
Subscribing to the code of ethics is still
The difference,
No.
The difference of being certified is you basically are automatically saying that you are following those code of ethics, and I think that sets you apart from somebody who doesn't. Yeah, no. But I just mean in general, like I have several knowledge of advocates that are not certified and don't have a medical background. And it scares me a little bit on some of the things that they do to help, because as a nurse and being passionate, I really want that person to get the most effective help. And there are some things that you just have either by being certified or by having some kind of healthcare background that's different. Now, I'm not saying that you have to be there are biller advocates that don't have healthcare backgrounds that can run circles around me in billing, and I will gladly. Absolutely. Like I can go so far and then I'm like, okay, I need help.
It's also a part of the code of ethics that you refer.
Yeah.
We don't work beyond our scope.
Exactly. And that's what I like about the code of ethics. And so I feel like it's kind of like having the hospital certifications, if you're JCO certified and whatever, it sets you apart. You have this bar that you're set apart, right?
I would also add that, one of the beauties of the coalition is that all of the participating organizations have all of their members subscribe to the code of ethics regardless. So, for example, GNA, you're not required to be a BCPA in order to be listed on GNA, But you are required to subscribe
Yeah.
to swear that you're going to have.
Yeah. To be certified by the PAC board exam, you have to subscribe to the Code of Ethics. To be a member at NAC or Health Advocate X, you subscribe to the Code of Ethics too. All the coalition members require.
I'm wondering how hard it is for a nurse who's a board certified patient advocate to know that fine line. If I'm acting as a nurse. Issue that somebody wants the nurse. I want your advice. You're a nurse. Tell me what to do. And then you get put in that spot to say, I'm not saying it happens. I'm just saying, oh no, it happens. It happens. It's probably a very fine line of I don't want to say ethics. I don't think it's ethics. I think it's morals or caring that you want to start with a man.
Yeah.
Well, I'm thinking of the heart. I'm not thinking of the pocket. I'm thinking about
You have to distinguish what hat you're going to wear, and being a board, because my background is in nursing as well. However, I don't keep up my nursing license. So I know that I have to stay in my lane, although, yes, I practiced nursing for 20 some odd years. I know that I can't say, well, this is what you should do. Now, I know that because I became, board certified, and this is a code of ethics that I'm, supposed to stick to, I stay in that lane.
But I would argue, even as an RN, my job isn't to tell them my opinion. My job is to, even as an RN, to advocate for my patient. Now I'm stuck between the hospital, the doctor, and whatever, in how far I go, because of course I could be fired, right? Because yes, I'm to take care of the patients, but if I want to get paid by XYZ hospital, then I need to follow the guidelines and not supersede what the physician says. But it's still my job as a nurse not to tell them what I think, but it is my job to say you have choices, explore them. Like I can say that. You know what I mean? Because I do still work and keep my license active, and it is a hard decision for me on many cases. Thankfully, I'm from a metroplex, so when people say, I don't want to go get my labs done, can you just draw them? I'm like, we have mobile lab. We'll get the doctor to send the order to mobile lab. So, but you're right, it's tough.
Our organization has been trained in 2006 caregivers to be patient advocates. We focus on safety and standards and policies and communication. It's a long course. We didn't do it long before it was board certified. And when Advocate came up with their ethics, she allowed us to use that as a study guide. And so when we did quiz, we used that. We had to say that they use this, so they were able to go into a hospital and document their family member, and at least have an idea of what ethics were, what they could and shouldn't do. But they would carry with them. They bring them some of them.
So if you go, we do encourage anybody in the domain. I wanted to go back to this. So now there's something right there that says ethics, where you can sign on to the Code of Ethics. There's a form you can fill out, your institution can fill out. Advocates can encourage other allied professionals to go to that code.
Told them what to do. They gave me advice on what to do. Board certified. What is the policy of the organization if somebody is somebody reports them?
Well, so
They can lose their certification.
You're taking it away. Well, no, my question is there a panel set up yet?
I believe there is, because when we
You
there
file a
is
complaint
through
to the PAC board.
yes, through the PAC board there
Okay,
is.
so you file a complaint to the PAC board, and
Yes.
somebody did not follow part of that. And then what is the policy? What are the steps that it takes?
I don't know those specific steps, but I can ask, and the PAC board probably has that well.
And that is really what I was thinking. That's the thing about this. Board needs to let the other organizations know that there's a bad apple.
File a complaint against an actor, and they say, "Oh well, we'll get to it in a few years." I'm sure that you rate the patient, but
I'm sure the PAC board has a formal process because they do everything.
Because hear 10% of what is said to us, and 90% we don't. And when it's repeated 3 times, so in my year and a half, almost 2 years of being an independent patient advocate, no different than being a nurse. I have a very good friend right now that's a client. My rabbi's wife had a massive stroke, and he looked right at me in front of a panel at a nursing home with his whole family. What do you want me to do? And I looked at him and said, here's all of your options. I can educate you on all of your options. I cannot tell you what to do. But he could have walked away from there saying, Terry said.
Which is why I want to know what
Right.
the policy is and the procedure is if somebody, right or wrong, I just curious.
Right. Then how do they
If
follow
I
up
go,
on
if
that?
I have a client that says, I'm gonna report you, I'll say, fine, here's the phone number to report me. What do
Yeah.
you guys do? What is that number? What is that process? What is the procedure?
Yeah.
I don't know.
Let's
Which
let
is
me
what was
get
frustrating
let me
me
get
about
more info.
when board certification first came out. My first question was, and if there's a problem, and they said, we don't know yet. Wasn't planned. So I mean,
They do have a formal process,
Yeah,
and
there is.
I'll find out what
So
that
maybe
is,
you
and
all
it
should
will
know
be a
that.
good. Yeah, I think it would be a great thing for us to help share that information.
Online.
File a complaint directly online.
Not-
They do.
Yeah.
When they
Yeah,
did the
done.
revision of the code of
My
ethics,
question is,
One more time.
when they did the revision of the code of ethics, that was part of it.
Oh, thank you. Thanks, Tammy.
You will.
I have another, and that's this: who know? I mean, does the patient know that they have access to this to even report it? Does everyone that takes the PAC and passes, do they know that, hey, if you don't follow, this is what you're supposed to do? Who tells the patient that you have?
Well, I think that that's a great point. I think it's a great point, and if it isn't, I don't have the ethics memorized in my head right now. I don't know if it's in there or not, but that's something that we can get clear on.
I mean, I tell my patients.
Yeah.
Like all the written.
Yeah.
We sign our service agreement or whatever, and I go over it with them in person, like where I got my agent, what I'm allowed to do, what I'm not allowed to do. If you have an issue that you can't resolve with me, here's my certifying body, go over that track.
Right. And
Yeah.
so,
Yeah.
and you also have a lot of patients. I mean, people that don't even know what a independent patient advocate is, and I mean, just how strong do they feel about still IPA? I mean, you have all those questions that need to be in.
What was the last part? They feel about what?
But you don't even know how they feel about an IPA, independent patient advocate. You have no idea. I mean, I tell people I'm an independent patient advocate, they're like, what is that?
Oh yeah, there's so much education that goes into just starting our relationships with our clients.
So, I mean, it's got to be a lot of education in the airways or whatever to tell people this is what an independent patient advocate is.
Yeah.
So that more people are aware of it, because until people become aware of it, it's just something that's talked about, and it's not an actual plan laid out on how you can reach the end result.
Yeah, that is one of the primary missions of the coalition. Yeah.
And of this
We
trip to
agree.
New Orleans.
Huh?
Yeah,
And of the trip to New Orleans. Yeah.
You weren't, is there anybody that third party or everyone's?
People, it is private pay. And part of the reason that the visibility of the profession is important is so that, and the coalition is together in general, is to think of creative ways to make sure that all patients have access to independent patient and healthcare advocates. So whether that creative way is more foundations, charities, and pools of access, or it is codes for those independent advocates that do want to be able to accept insurance, which is something that people feel differently about, and it kind of depends on the scope of work. Bridget, did you have a question?
Just as with regard to if you have an RN or some sort of medical license, separating you, it's very important for an independent advocate to have a contract and agreement that specifies those boundaries. My contract is extensive, written by an attorney, and
you have to spell everything out. I can do this, I can do it, I can do that. In your contracts. And this is also why certification is important, because when you get certified, you're basically saying, even though I have an RN or whatever license, I'm not gonna practice that in this role. You're agreeing to that with your certification. That's one good thing about that. The other thing is having a nursing background. I keep extensive documentation, as I have learned as a nurse. And so, patients may accuse me of, like, she told me what to do, but I have a lot of documentation showing these are the options that I gave my patient. And I even say to the patient, here are your choices. Let me know what you think or what you decide. I almost always have their decision in writing, especially when it comes to clinical things like chemotherapy, cancer treatment choices, things like that that could really make a huge difference. What they choose, I make it very, very obvious that I give them the options and they made that decision.
I never give one option.
Yeah,
never ever. Any other questions? Did I answer your question well enough that right now we're figuring that out? Yeah. Okay. Okay. Great.
Thank you.
Thank you so much.
Put your,
Yeah. Those were handy.
yeah.